Thank you, Dr. Hassan. It's an honor for me to be with you and with this elegant foundation, EFRE, and to speak after elegant speakers. I wish I can say a clear message about deep endometriosis. Deep endometriosis is the hidden threat. First, before I start my lecture, I want to ask you about a case. Any one of us can see this case at our clinic. It's a 32-year-old female complaint of primary infertility, 3 years, and deep dyspareunia. AMH was 2.3, TSH 2.5, prolactin 29. Semen assessment for the male partner was 5 million, G3 or rapid progressive 5%, normal morphology 3%. Ultrasound examination show a picture of pouch of Douglas obliteration with 2 centimeter nodule at the upper part of the rectum. No evidence of hydrosalpinx or adenomyosis. So I want each one of us to think about the next plan or the plan for this case, to operate or to go ahead for ART without surgery. So deep endometriosis is endometriosis infiltrating the peritoneum more than 5 millimeters. We can see deep endometriosis in about 1/3 of cases of endometriosis. The most common sites is uterosacral ligament, rectosigmoid part, and vagina, and last bladder and ureter. Diagnosis of deep infiltrating endometriosis, the vast majority of cases of deep endometriosis will not be diagnosed at all by clinical examination. But you can suspect cases of deep infiltrating endometriosis with cases of invalidating hypogastric pain with severe dysmenorrhea, deep dyspareunia, severe chronic pelvic pain, myocalgia, severe menstrual myocalgia, and radiation of the pain to the perineum. Dyschezia, severe dyschezia, menstrual blood on stools, menstrual diarrhea. So these cases can be suspected to have deep infiltrating endometriosis. So I can confirm my diagnosis by doing transvaginal ultrasound. I can see hypoechoic shadows, sometimes poorly delineated areas, roughly rounded, infiltrating organ or its location, and they may occasionally contain hyperechoic foci. When you press by the transducer, you elicit deep pain at the site of endometriotic nodule. The IDEA group, or the International Deep Endometriosis Analysis Group, put a method for, or a scheme for diagnosis deep infiltrating endometriosis at 4 steps. The first step, by routine evaluation of uterus and adnexa, sonographic signs for adenomyosis, such as Sylvia said, and the presence or absence of endometrioma. Second step is evaluation of transvaginal ultrasound for soft markers, site-specific tenderness at the pelvis, and ovarian mobility or fixation. Third step is the sliding sign. Fourth step, to assess the anterior compartment and posterior compartment for the location of the nodule and measure the size of the nodule. So tenderness guided transvaginal ultrasound is a good method for diagnosis of deep infiltrating endometriosis, especially if you put 12 millimeter of ultrasound gel instead of 4 millimeter in order to see near or superficial parts to the transducer, to decrease the blind point or the blind area in front of your transducer. Sliding sign is a good sign. So transvaginal sliding sign technique to detect pouch of Douglas obliteration in women with suspected endometriosis is highly relevant. Meta-analysis reports shows that its sensitivity about 83% and specificity about 97% for diagnosis of deep pelvic endometriosis. Sliding sign, as we see, uterus move separately from the viscera, from the rectum or the rectosigmoid. There is no area of attachment. Frozen pelvis masking the retrouterine excavation by a block of tissues with lesion of the posterior pelvis, such as torus uteri or uterosacral ligament, vaginal and rectal wall invasion associated with adnexal adhesions. Frozen pelvis may mask deep pelvic endometriosis. This picture videos from the courtesy of Prof.Dr. Dalia Al-Haig. As we see this video, there is adhesion between the rectum and the posterior part of the cervix. There is no complete sliding sign, so there is a suspicion of deep pelvic endometriosis. This video shows adhesion between the rectosigmoid and the back of the uterus. Here, uterosacral ligament, there is a nodule at the top of the uterosacral ligament and attached to the retroverted fundus. And this is also a nodule at the level of the uterosacral ligament. This video shows triad of chocolate cyst and deep invasive endometriosis at the level of the rectum and also near the uterosacral ligament. Here with this tube ovarian complex, we can see also a nodule in between the adhesions between the two ovaries and the uterus. So you can suspect deep infiltrating endometriosis with kissing ovaries, with tube ovarian complex, with adenomyosis, or adhesions between the uterus and the rectum or the rectosigmoid. This is the triad of chocolate cyst and nodule over the rectum and nodule at the uterosacral ligament. This is a nodule between two kissing ovaries, nodule at the back of the uterus at the insertion of uterosacral ligament. All of these pictures from courtesy of Professor Dr. Dalia Al-Haig. Thanks, Dr. Dalia. About accuracy of ultrasonography in diagnosis, it's about 98% accurate for intestinal lesions. Uterosacral ligament nodules are diagnosed in up to 78% and adequately excluded in 88% of cases. The least it was the vaginal lesion. About 25% only of vaginal lesions was diagnosed by transvaginal ultrasound. We can increase this ratio, as we said, by increasing the amount of gel in front of the transducer in order to diagnose superficial lesions to the probe. MRI is the second choice, which is less operator dependent, provide information about lesions at the level of the sigmoid colon. MRI should be reserved for equivocal ultrasound results in case of rectovaginal or bladder endometriosis. Colonoscopy is invariably negative in most cases, but it can be positive only in large nodules, which reach the submucosal or the inside the cavity of the colon. Most of the cases, the lesion starts at the serosa. It can infiltrate the musculosa. Rarely it can reach the mucosa or the cavity. So in large lesions only, we can diagnose it by colonoscopy. CA125 isn't very useful for the management of deep endometriosis. So conclusion number one, diagnosis by history, transvaginal ultrasound, plus or minus magnetic resonance. We have 5 questions about infertility associated with deep endometriosis. Can deep endometriosis affect fertility or not? Does its removal improve fertility or not? Can it affect IVF outcome? Can surgery improve IVF outcome? Does it affect obstetrical outcome after IVF or after spontaneous pregnancy? First, infertility. In women with deep endometriosis may be infertile, but deep lesions may not be the sole cause of infertility. Evidence is insufficient to definitely support a causal relationship or to claim a decisive benefit of surgery. So there is no strong evidence that the deep endometriosis is the sole or the main cause of infertility in case of endometriosis. There are a lot of confounding factors such as endometriosis per se, adenomyosis, adhesions, or associated conditions. So, effect of surgery. There is non-randomized trials. Some are controlled and some are not controlled. After 24 months of follow-up, pregnancy rate was 36% in expectant management women, and it was 34% in women choosing surgery. There was no significant difference. A systemic review by the same author showed less optimistic results, only 24% success rate for cases of surgery. About 3 systematic review showed improved pregnancy rate after surgery, continuous pregnancy rate after surgery. It was about 42 to 44% cumulative pregnancy rate. As regards IVF, also lower success rate could also be explained by the association with endometriosis in general or adenomyosis. There is no solid evidence that deep endometriosis is the sole cause of IVF lower outcome. What about impact of surgery on IVF outcome? No randomized studies also. Only controlled studies there were 4 studies. The first, done by Bianchi et al., found that the pregnancy rate per cycle was significantly lower in the non-treated group, 24% compared with the treated one, about 41%. Also, another study showed that lower pregnancy rate in cases of endometrioma with deep endometriosis than cases with endometrioma alone. The other 2 studies shows no effect. But these studies are scanty, weak, and contrasting, and there is a confounding factor affecting the results, such as endometriosis, adenomyosis, and previous surgery for endometriomas. What is the impact of IVF therapy on deep endometriosis? 8 cases of deep endometriosis showed a progression of the case and appearance of some complications, such as urethral and intestinal complications. Intestinal perforation and pelvic vessel rupture was also one of the complications in these 8 cases, but is a case series only. What about obstetrical complications of endometriosis, of deep endometriosis after pregnancy? The strongest evidence shows that deep endometriosis is associated with a high rate of placenta previa, but there is a controversial evidence about miscarriage, intrauterine growth retardation, preterm birth, and hypertensive disorder. Also, there is no study investigated the effect of surgery on the outcome of pregnancy. So, conclusion 2, no solid evidence regarding infertility and ART in deep infiltrating endometriosis, either for surgery or for conservative management. So, what about management of deep infiltrating endometriosis if you want to manage? There is an individualized approach. No surgery in cases with asymptomatic infertile women or those who with pain symptom can be effectively managed by medical treatment. So you can go ahead for IVF without surgery, or you can do intraperitoneal surgery. You can remove chocolate cyst adhesions or hydrosalpinx, but don't go beyond the peritoneum, don't go deep to deep pelvic endometriosis. You can use also medical therapy before IVF and stop medical therapy during the IVF cycle. You can improve results and relieve pain if there is associated pain. But you can refer to surgery in some conditions, such as pain symptom because medical therapy is ineffective, or medical therapy can't be prescribed because of unbearable side effects, intolerance, or risk. Clinically relevant intestinal or urethral stenosis is detected if there is massive stenosis or major urethral stenosis or intestinal stenosis. It may worsen the condition by stimulation, so you can go for surgery first and then go to IVF. Young women who had repeated IVF failure, despite of adequate response to ovarian stimulation, you can do surgery before the next attempt of IVF. So if you go to surgery, shave deep endometriotic lesion or excision or intestinal resection. No evidence was found that long-term outcomes differed when nodule excision was compared to rectal resection for deep invasive endometriosis. So shaving or resection of the nodule or power resection, there is no difference as regards the recurrence or the outcome. So if you do surgery, do the least. So conclusion number 3, number 1, you must counsel the case about the risk-benefit ratio, about major surgery, about major morbidity after surgery, about risk of intestinal resection, about risk of complication before you go to surgery. Also, there must be a good, efficient surgeon before going to such a major surgery. Also, there must be a good equipment, good endoscopic instruments before going to this surgery. So you must put a balance between risk and the benefit before choosing the proper method for management, either to conserve and go ahead for IVF or do surgery and go for IVF. If we now go to the first case or the first slide of our presentation, I think most of us can put a plan easily now for this case. Thank you.
Thank you very much, Professor Mahdi, for a really excellent presentation.
Thank you.
With a clear point of view. Thank you very much, my dear friend.
Thanks.
And you showed clearly that this is an area of research.
Mm-hmm.
Don't have enough evidence.
Mm.
And also, I felt from your presentation that it's a multidisciplinary approach that needs a specific place to be done in. It cannot be done in any center or any hospital.
Mm-hmm.
This needs a center of excellence, like the one you and I visited in Bologna 10 or 15 years ago. They were doing like 10 cases of deep endometriosis a day.
Mm-hmm.
And of course, Professor Bruce Lassie, who in the centers of excellence they have. So I would suggest that this type of surgery, if it needs to be done, will only be done in a center of excellence. So what's your comment on this? And I will leave Professor Bruce Lassie after that.
Surgery for
center of excellence.
Surgery for deep pelvic endometriosis need a teamwork of urologists and GIT surgeon and the gynecologist, and after that for also rehabilitation of the patient for returning to life, to returning to sexual life, returning to reproductive life. So it's a multidisciplinary approach, not a one-man show. It needs good instrumentation, good staplers, good telescopes in order to see planes of tissues, in order to dissect safely, to work safely with the patient, in order to decrease the surgical time because it's tedious and major surgery. So it needs a teamwork first.
Professor Lassie, multidisciplinary approach that needs a center of excellence.
Yes, I agree. I think it's so dependent on the quality of the center. It's so frustrating to see patients who have come in and already have surgery by a generalist who looked in and then didn't do anything. So it's critical.
Yeah. Professor Mahdi, deep endometriosis and infertility, again, deep endometriosis and IVF.
In a straightforward case, first IVF attempt, no other risk factors.
No, first infertility, Mohamed. First infertility.
Infertility.
Deep endometriosis and infertility. If this is the only finding, would you do anything about it?
Nothing. Wait and see. Gives a chance for natural conception, gives a chance for intrauterine insemination. If no pregnancy and diagnosed otherwise unexplained away from this nodule, I go ahead for IVF. If there is a recurrent IVF failure and there is nothing at all except this nodule, I can go for resection of the nodule.
This is similar to the small endometrioma of Professor Bruce Lassie.
Like
Professor Lassie, what do you think about this? Deep endometriosis and infertility, deep endometriosis and IVF?
Well, I think if the patient has pain, they get surgery. If they have infertility only, I would not do surgery. Perhaps if they fail, then you should look into suppression, assuming that the inflammation is causing some endometrial receptivity problems.
The end of the presentations will be provided by Professor Mahdi and the IT. They will show the vote and we'll show the answer to that vote. And we thank you all before we go to the vote. Bruce, I cannot thank you enough for being with us. Thank you very much. The vote, Professor Mahdi. So each one answers, and you submit your answers at the end, please.
Yeah. I think time is enough, Akram.
Okay.
Can we see this answers? If you look to the first question, some in vitro studies show that the presence of endometrioma negatively affects folliculogenesis. 73% with a correct answer, which is yes. Regarding the endometrioma and infertility, choose the correct answer. All of the above, about 52% was the correct answer. In case of laparoscopic surgery for endometrioma, excision results in better pregnancy than ablation. Yes, 60% was correct answer. Question number 4, endometrioma-related infertility are related to surgery rather than the presence of endometrioma. The correct answer is yes. Half of the responses was positive and the other was no. It is yes is the correct answer. Dr. Hassan. Dr.
Yes.
Hassan, can you
Yes.
comment on this question, please?
Endometrioma-related infertility are related to surgery. The presence, clinically, the presence of endometrioma itself is not related to infertility. Rather, it is the surgery that is related to infertility. So this is my response.
Yes or no?
Yes.
Yes. Endometrioma surgery should be routinely done before ICSI to avoid cyst infection, complications during a pregnancy, and to avoid cancer development in later life. The result was no, which is the correct answer. Are thrombophilia factor 5 likely cause of implantation failure or recurrent first trimester losses? The correct answer is no, but most of them answered maybe. So,
can Professor Lassi comment on this?
So there's an interesting series of studies by Burton out of England showing that the placenta does not have a blood supply until 10 weeks of pregnancy. So it'd be very unlikely that thrombophilias could affect early pregnancies because there's no blood supply to affect.
What's your opinion, Dr. Hassan?
I don't have opinion after Bruce Lassi.
Number 7, what is the function of SIRT1? The correct answer is C, histone deacetylase, but most of the answers was number 4, transport protein.
It reverses the genes that progesterone upregulates. That's correct, Bruce?
That is correct. You listen.
This is the way you phrased it, right? Can you comment on CERT, please, Bruce?
The comment on that histone deacetylase?
Yeah.
Yeah, there's 10 or 12 genes that it turns off that are involved in implantation, including some many you'd recognize. So we're looking at that now with some RNA-seq.
So number 8, what is the expected live birth rate with euploid embryos? It's 55%, which is the correct answer. Number 9, adenomyosis in 30% of women is asymptomatic and found only. Yes, this is the correct answer. Adenomyosis is associated with associated to endometriosis. Yes, is this the correct answer? Is in 40 to 50% of cases. This is the last question in the voting. Thank you. Dr. Hassan?
Professor Lassi, we apologize. You had 2 figures that they couldn't put into the voting, but we will put them on our site on Facebook and we will send them to all the audience.
Very good.
Thank you very much. Thank you very much, Bruce. Indeed. for an excellent presentation and for being with us till the end of this marathon webinar.
I was honored to be here. Thank you.
It's our honor, sir. And we will forward with you about the research that we want to do in EFRE. Probably you will guide us in a simple research, something that we can afford.
Yeah.
Thank you very much. Thank you, Professor Kortam, for your excellent presentation and for being with us. Open the voice, please. And thank you, Gabriel. Thank you, Mahdi. Thank you for all the speakers.
Thank you very much, Professor.